So thank you for having me. Without further ado, let me jump into the topic. And thank you, Tikam, for inviting me, and thank you for inviting me to this wonderful conference. And I really would like to bring a slightly different perspective to this particular platform, particularly in terms of how we prepare ourselves for the next pandemic, right? So let me jump straight into the topic. Oh, by the way, my name is Eric Wu. I'm from Malaysia. I work for ECRI, Asia Pacific office. We are a non-for-profit research organization that we share a lot of our findings to ensure patient safety. So today, this is the outline. I'm going to talk a little bit about whether we are really ready for the next pandemic or not. And let's look at what are the evidence related to how we have been dealing with pandemic, and I don't have to tell everyone what we have gone through, but I just want to put some facts on the table in the beginning to talk about whether we are ready for this sort of pandemics to happen again. So that's one. And I will dive in a little bit about the importance of having this emergency preparedness plan. It can be a hospital level. It has to be a hospital level emergency preparedness plan. It can be a state level plan, and it can be a national plan. So, but there are some similar consideration factors that has to be put into when we think about this sort of plan. And we want to move forward and build, hopefully, our healthcare into a learning healthcare. And what are some of the strategies that we can really think about in terms of going towards a learning healthcare perspective, right? So all this while, we have been looking at, when there's a pandemic, we look for innovation. We look for innovative ways to diagnose our patient. Like now, those days, RT-PCR was really not something we do every other day, and it's hard to come by. And because of the pandemic now, RT-PCR is like everywhere, and it's such a common diagnosis tool to use today. And we will continue to look forward to more innovative diagnostic equipments as well to help us deal with the pandemic situation that we will face, right? We also look for innovations in terms of how we treat the patients, things like vaccines, things like methods of dealing with the patient, how we isolate and stuff like that. We also use a lot of math modeling, particularly we can see in almost everywhere we go, there's always a tracking or an identification model where we can look at what are the stats, where are the areas of risk. R naughts have been very common now with the recent pandemic. The infectiability of all the patients with diseases. So I think a lot more maths modeling are going to be presented as well and being created so that we can continue to monitor. We also look at when pandemic happens, a lot more innovation in digital platform. And of course, of late, everybody talks about telehealth and telemedicine. Those are digital platforms that are sort of being discussed today that are now going to change the landscape of how we provide care to our patients in the hospital itself, right? But today, in what I'm going to discuss really related to emergency preparedness is not about those innovations. I'm going to talk about what we do during the outbreak and during the pandemic. The question is, how do we use facts and evidence to help us become more ready when we deal with the care during the pandemic or during an outbreak? Not after, not before, right? But we do want to use as many data, as many lessons that we have gone through to help us prepare for the next coming pandemic. So the question is, are we ready to look at all those data? Are we ready to analyze those data? Do we really understand what we have to look for? So those are the things that I want to put into the perspective of today's presentation. And I'd like you to take home thinking about, what can we think for the future? How can we use today's data and how can we use today's experience that we have to help us for the future itself? So let's look at what has been challenging for us during COVID-19. So here are some facts that I'd like to take you through. Supply chain disruptions. They are continuous shortage of medication. Today, even in the current wave of COVID-19 that we have, say in Malaysia, for example, we are experiencing shortage of medication. We have shortage of cough syrups, we have shortage of flu tablets, paracetamols, things like that. And obviously, those are going to impact the public at large because people cannot get hold of medicine. There's just a shortage of medicine, let alone when it is during the pandemic itself. So we have seen evidence that there are a shortage of not just the medication, but also the equipments and consumables and supplies that they need. So this is really a factor that we really have to take consideration for the following future. And for us here in this platform, we should be thinking about how can we learn from here and what kind of data and statistics we can pick up from here to help us identify potentially what could be the thing that we need for the future and how much do we need to do that. So these are some of the evidence. The other one that is very important is that some countries, like the United States, have stockpiles. They buy a lot of stuff and they keep that and ready for an emergency use. We also have seen that some of the items that were procured were probably a decade ago and probably are not sufficient to deal with today's cases. We have seen challenges that things that you need for this new disease pandemic may not be the same as COVID-19, and that we have stockpiled the wrong stuff, right? And if we stockpile some things and we cannot stockpile everything, it's oftentimes insufficient because when a pandemic happens, the spread is too fast. And there's too many people, you are unable to cater for that volume of increase in terms of patient coming into the hospital itself. The biggest challenge is, as we have seen, and when we lock down, we can never replenish any of our supplies. So that is going to be the one very big challenge that we can see. And it has happened during our current COVID-19 pandemic itself. And these are things we have to, sort of factor in and learn about it. Some stuff that we buy in the stockpile that they have, it's a good idea to have stockpile, but when you keep it too long, it got expired. So rotation of products and stockpiles that we have were not really performed, and process to deal with that should be enhanced and updated so that we can improve those things, right? Things like battery discharge, we have seen a lot of those missing equipments in the stockpile, products physically damaged because they were just in storage and nobody was using it to begin with. So those are certain challenges that you can see in terms of supplies and equipment during the pandemic itself. The next challenge we see a lot, and this is a big complaint, and I think moving forward for the next pandemic, we may have a bigger crisis in this area. People or staffs has now experienced a big pandemic management. Already before the pandemic happens, we are running short of nurses. Statistics or studies have actually shown we're not just running short of nurses, we're running short of physicians, we're running short of technicians, and we're going to be in big trouble long term because we will be running short of all these key front lines that we will need to deal with the pandemic itself. Now, with the recent experience where we have also seen that there is a very high risk for staff to be contracted with the disease, and there's also mortalities that are involved in the staff that are dealing with the disease factor. My biggest fear is that these numbers will increase when we see the next pandemic happen, because everyone's going to try and safeguard themselves. And we had this experience now because people have seen it, they've tasted it, and they have actually experienced it already. So this will be a very big challenge that we have to really take consideration, and how do we deal with these challenges, and do not wait for this the next pandemic to happen and we have to deal with this shortage again, right? We have also did a lot of studies, and we found that even if you can get supplies, some of those supplies are really not up to mark. It doesn't do the job. things like the face mask that we have studied on, and we have actually took those physical products and studied on, and we found that a huge number of percentage doesn't really meet the criteria. So if you're wearing a mask and dealing with a patient, you're going to get contracted with the disease, and you probably get COVID as well. So it's like you're not wearing those protective masks for the staffing itself. So we also see that even if you can get supplies, you're going to be getting supplies that potentially can be substandard. And we've seen that in the gowns as well. And so these are also challenges that we see. And we, not only that we have to deal with the patient, but we also have to deal with already the shortage of manpower and frontliners that we have today. And if these are contributing to a lot more scarier experiences for the staff and clinical people, it's going to be even harder to get people to work during the pandemic itself, especially the front line. So these are also issues that we have seen challenging us in the pandemic world. We've seen a lot of new adoption of new high-tech technologies. One of those very funny videos you can see on the left side, relying on consumer grades. We've seen that, coming out with new devices that were not used, and then now they want to use it. Let's talk about the consumer grade stuff. And I experienced this personally as well. My friends were calling me, should I buy an SpO2 digital monitor and put on my finger and monitor if I have my breathing is good, I have enough oxygen in my blood. Somebody was saying that, can I buy an oxygenator and put at home, so I put it on my face mask and I can get more oxygen than I need, so that when there is a problem where I don't have enough oxygen, I can use them. All these are, untested consumer grades. They're not medical device. In fact, during a pandemic, medical devices are short too. So even the hospitals cannot get hold of enough medical device, let alone the consumers. So imagine that this sort of pandemic will create a huge market for consumer people or general public to be hunting for medical device for monitoring itself. And a lot of times they get themselves into trouble because they're using devices that are inaccurate and cannot be giving them the right diagnosis that they need. But this has been also a problem, like the SpO2 on the finger. I've seen a device that was, don't know manufactured from where, but somebody put a pencil and clip onto the machine or the little device there, and we can see digital numbers moving, and we can see the SpO2 rate. So we were wondering why is a pencil having an SpO2 reading? So that's the funny part. UV lights, everybody says we've got to disinfect our hospitals, we're going to use UV lights. Not only just we're going to use disinfection, but we're also going to use UV light. Proper design of the UV light can help, and UV light is not all the answers for disinfection. It's a complementary device, and it has to be properly designed. It's a complementary device to how we are cleaning and disinfecting our our environment, so that the viruses that are around us can be destroyed. But it is not a silver bullet that you can just buy a UV disinfection device and it will solve all your infection problems and your staff and patients are safe. That's not going to be the case. So we found that all these hype technologies were just being introduced just to sort of get into the marketplace and sell. And sometimes those design of devices don't even reach the level that we need. And you can see a lot of recalls and a lot of warnings that are coming up. So how do we deal with all this who wants to take advantage of the situation as well? And we have to be very clear how we manage such a situation. We also see improvision, and this is innovation, really, truly. We've seen a lot of people try and improvise. So because they don't have enough PPEs with them, so they sort of put the equipment all outside the room, and they put extended tubes connecting pumps that are supposed to send in some solutions to a patient, a longer line of tubes. And from outside the door, they sort of tube it all the way into the patient. Now, that is an improvisation, and the pump is designed to be a bedside, and the tube is only one set, and they use it commonly in a very sort of managed distance near to the patient itself. But when you extend it all the way out to the door, your settings of the machines and all that, it can be compromised. and that could be a big challenge. We've seen people trying to use one ventilator for two patients, and somebody in New York was standing out there and starting talking about, oh, we did it. We used one ventilator for two patients, and not only that there's cross-contamination issue, because okay, both of them has COVID, but still, how do we manage two different patients? And you're taking a very big risk with one machine because the machines are designed for individual use and not two patients use. And we see all these things. So how do we deal with these things in the coming pandemic? And do we still want to take this sort of risk? Some people even design an iPad where they can remote control the device from outside the room. And that poses a secondary risk as well when you design something like that. You don't know whether it will work all the time or it won't, but it has been done. So these are risks that we have to really think about. Then there's this big hype about telehealth. There's a huge adoption of telehealth during the pandemic, and people say that telehealth is our solution when there's a pandemic and stuff like that. Yes and no. That's what we want to say, and you got to take note of all this. The study has shown that telehealth today are limited to teleconsult, and teleconsult means I can use a Teams call, Zoom call. I can see your face, you can see my face, and the physician's going to be talking to you. That's teleconsult. But how much can that do? If I need to know if you're having a cough and your lungs are congested or not, I can't even put a stethoscope on your chest. And how do I prescribe medication? And some people do that. So telehealth is good. It's here to stay, but we just need to make sure that we understand what kind of patients are sort of good and qualified for this particular kind of technology, and not all patients are slated for this technology use itself. So we've got to think about that and how do we use it properly, and also remember the clinical guidelines that we have, our liability that we have when we use telehealth as our means of caring for our patient itself. So those things has to be thought through too. We also see a lot of cybersecurity, and during the pandemic itself, a lot of report has been reported, and many hospitals and healthcare systems were hacked. And a lot of times they will hold ransom, and they have to pay digital currency so that they can pay digital currency ransom so that they can get all their system back and running. So utilizing a lot of system technology and integrated is also a risk. And this is also not a risk that we now want to talk about, but it is a real risk, right? We've seen because of ransomware, patient has actually died, and that was the first case that we read about, and it has been very challenging on top of managing a outbreak and communicable all this disease that can be transmitted very easily. We have to deal with all this as well. So as we introduce all this technology, and how do we introduce all this technology, and how do we prevent all this risk, is another factor that we have to really think about when we are caring for our patient in the hospitals. The other complaint or the other issues that has been widely reported, and I'm pretty sure everyone is aware of this, is the insufficient of beds. We will not have enough beds, and we did not have enough beds during COVID-19 anywhere in the world. And anywhere in the world, healthcare systems, you will see people lying on the corridor, sleeping outside the triage area. They're everywhere because we just don't have enough beds. And no matter how you want to cater for it, we won't have enough beds. And this will be, again, a continuous problem for the coming outbreak if it comes to come to our shore. So what should we do, and how should we think about this, and what are the potentially evidence that we can learn from, or lessons that we can learn from today, and to help us better prepare for tomorrow? And we'll talk more about that. So I'm going to jump into the emergency preparedness plan. And what I'm doing today is just to share with you some framework thoughts. And there are a lot to this framework, and there's a lot of details that we have to study within that framework. But this is I hope what I'm hoping today is that when I share this framework, you could actually have some thoughts to it, and hopefully we can start looking at what we can learn from yesterday and bring it forward for more preparedness in the future itself, because this is no longer something that we can say it won't happen. It's likely to happen. So what are certain key consideration factors? In emergency preparedness, I think these are the four key broad factors that we have to really think about. You have to assess your risk today. once you understand your risks, you have to plan how we can mitigate them. You have to create policies and procedures under the emergency preparedness, which means pandemic time, not peacetime. So you have to have a new set of policies and procedures ready that will address the whole protocol, taking in consideration all the risk that is associated to it. And you've got to have a plan that covers those range. So when a pandemic really or an outbreak comes to our shore, we are able to sort of bring this book out and execute and implement according to the plan and policies that we have. So learning from what we have, the data that we see today from the pandemic will help us run our operations, managing potentially the new outbreak patients much, much better. The other key thing to think about is communications. And during this pandemic, we learn a lot about communication problems, both internally when we are caring for a patient, and also how we are communicating with the public, and also within the care system itself. So we have to think about what are the communication plans and who should be doing those communication plans. And importantly, when you have a plan during peacetime, please do more training and run your drills. And it's not a joke, because without training people to deal with this protocol, they will forget. And when they forget, they will not know how to deal with it when it happens. So those are the key areas that I want you to think about. And when you're assessing your risk and when you're planning for solutions, please think about these three parameters. Take consideration of the people involved, both patients, caregivers, management, public at large. Think about the process during care and what are the risks associated to the process during care, and how should I improve that when a pandemic happens, right? And then have a good decision and what kind of technology I'm going to use. Do I have stockpiles? Do I have consumables? Do I have my medications ready? How do we deal with those that can optimize the initial care that we need to give to a patient when an outbreak happens, and later on when it becomes a pandemic itself, right? So these are areas that we have to think about during risk assessment work that we have to do. Communication, some key areas you have to think about. Number one, make sure you comply to the law, local law. It has to be very accurate. You have to have an efficient sort of a communication route. So don't make communication complicated during a pandemic or an outbreak. It has to be as straightforward, as efficient as possible, or effective and efficient as possible in terms of that communication route. So you got to think about how that route would be. That is inside when we are doing the care within a healthcare facility. It can be within the health system or state level and national level. That has to be thought through, and how we can communicate that well, so that there is no double guessing as to who should I tell and what should we do, and who should be telling certain things or saying certain things or giving certain instructions. So those things has to be defined. Identify key communication criteria. So what should we communicate in the hospital? What should we be communicating within the ward where the patients are? And we just need to make sure that those are listed down. Anything more than that are not necessary to be discussed and communicated. Focus on the areas that we want to communicate that will lead to the care of the patient. And that's the key thing. So when you're designing the protocol and policy, these are things that you have to think about from an individual ward level to a hospital level to probably state level and national level as well. And once you have all those things, take another eye and put on a new dark glasses and look at what are the impact considerations in your communication plan. And that's very important as well to think about. Training and drills, I talk about this. People say that we have an emergency preparedness plan in my hospital. We already have it. Question is, how often do we review it? How often do we update it? It could have been written in the 1980s and still same book and same thing there. Question is, when we also have like COVID-19, did we actually comply to our book that we've written? If it is updated, and probably if it's written in the 1980s, it's probably no longer relevant for how we're dealing with our patients today. So that emergency preparedness plan is irrelevant for now. So how do we utilize those kind of plan? And to the next point, is there really a plan? Is it new or is it outdated? And just an example, an influenza plan versus a COVID plan will be very different. How do we deal with that emergency? It's going to be very different. The differences may to some people very little, but it's very important. So if you don't have an updated plan and don't have a more comprehensive plan, then you're going to be in trouble. And then in those plans, when we train people, do we talk about who is responsible and what should each and every frontliner's role is, what should they do, from triage all the way to isolation wards, in fact, down to the surgical wards as well, if we need those. So this has to be well communicated, well documented, well communicated, well trained. So those people who are involved got to go through the training and run through drills again and again so that this will be part of what they have to do, right? Um, Training and communication, we also need to train the front line how to communicate. And before I go into that, I'd like to thank all the frontliners. They have done an extremely well job in managing the pandemic that we have, and they're still doing a good job today because we still have new waves. But we need to come up with what they should be communicating, and especially whether you're a doctor, a nurse, a police, delivery guy, um, whether you're a restaurant owner, there are things that they need to understand. And so managing pandemic has to be more than just a healthcare facility, because if everybody else understand how they need to deal with this sort of outbreak, then it makes the hospital a little bit better. We may not be getting so many patients coming in. And those kind of communications are important. And I think from the national level, this is something that they must put into their belt and or their book, and that they should execute a proper communication for when an outbreak happens. Some very quick lessons to learn and to think about when we design the next emergency plan for the coming pandemic. So we must learn that we were not ready for COVID-19, and it's evidential. We know that now. We will never be 100% ready for the future, even if you would take all risks in consideration and you think everything through. But know this, ladies and gentlemen, we will never be 100% ready. So the key thing to learn from and take home is really identify, understand, and analyze your risk. Learn from the identified risk. So a lot of data and a lot of information related to how and what has happened in the last 2 years when we deal with the current pandemic, and don't let all this information go to waste. We've got to really use them and learn from them. We can innovate when we plan for it in the future, when we understand those risks that we have faced in the last 2 years. Care during a pandemic is very important. It's important, and I know innovation to a lot of people is important, but care during the pandemic is also equally as important. And we have to really make sure that we have a plan to provide those care during an outbreak or a pandemic itself. So build and develop, update your emergency preparedness plan. Make sure you have a health emergency management system in place so that when this happens, it triggers the plan and it triggers all the protocol and work that you need to do and deal with, right? Sharing of resources, stockpile is one of those programs that I think we will still need to have. There's always a big question, how much is enough to stockpile? I don't have a good answer for it. We will have to do more studies and more investigation into what will be an adequate stockpile and what will be an adequate stuff to be keeping. But stockpile seems to be still the prevalent mechanism to deal with shortages, and evidentially the reports have shown that we have been shortage of equipment and supplies and medications and all that, and we have to think about how we will have to deal with this. So stockpile still seems to be the plan, and you may want to think about stockpiling program within your own hospital itself, right? Training is the last piece. We find that during the pandemic, there were many volunteers as well. Many physicians who were not at the front line of emergency were putting themselves into that place so that they can also offer care. And there were a lot of front lines that were also trying to deal with that part of the patient load that is coming in. When you have a plan, I suggest that we have a training module that is built in, and it has to be multidisciplinary. Training doesn't mean just the clinical work that we have to do. It includes how we communicate, what we have to do in communication, how do we manage the patient flow, how do we manage the physicians and also the frontliners that we have. Do not burn them out again. Do not create another mental health problems for our frontliners again. How do we make sure that we rotate them enough so that we can get a healthy group of frontliners continuously going into that battlefield for us when the next pandemic happens? So I just want to leave you guys as well. We publish this report for free every year. You can actually log into ecri.org and you will find some of this published report for free. We also have a COVID-19 center that is still open for public for free. There's a lot of resources that you can look for to talk about that. So my last bit is make sure you have a plan. So understand what it is, utilize the current data that you have that are mounting, especially in the areas of during pandemic, not after and not before. Looking at what we should be doing during pandemic, it's very important. Thank you very much. This is my last slide and I'm open for any questions.